Hello, my name is Carla, and this is my concept map presentation. This is a 67-year-old male, full code with allergies to cyclobenzaprine, hydrochlorothiazide, lisinopril, and NSAIDs, and he has a past medical history of alcohol use disorder. He drinks 6 to 8 beers per day. He has dyslipidemia, GERD, hypertension, peripheral neuropathy, and seizure disorder, and his primary medical diagnosis is alcohol withdrawal. Patient considerations. So, this patient is diagnosed with alcohol use disorder. He says that drinking is his way of alleviating the pain caused by the recent passing of his friend. He lives alone in an apartment complex with his dog. He was married twice. So, his first wife passed away when she was very young, and then the second wife divorced him many years ago. He does have a cousin, but he says that his cousin really isn't a support. He supplies him with alcohol every week, and he does receive food from Meals on Wheels because of his mobility. And the patient made it very clear that he has no friends or family that will support him after he is discharged. So now we're going to talk about patient discharge considerations. So the physical therapist did recommend that the patient should be placed in post-acute rehabilitation due to his impaired mobility. The patient is willing to go, however, he is hesitant about it because there's no one to take care of his dog, and his dog is extremely important to him. So, after a case management consultation, the patient determined it would be best for him to be discharged home and arrange home health management. However, his nutritional status is still a concern to me. Meals on Wheels does deliver food to him, but he says he doesn't really like it. So, based on my clinical judgment, it would be a good option for this patient to be referred to a registered dietitian consultation so that he receives education about nutrition, as it is extremely important for his impaired mobility status. The pathophysiology of alcohol withdrawal. So, alcohol is a central nervous system depressant that enhances the activity of GABA. In chronic alcohol consumption, the balance of GABA and glutamate activity signals become disrupted. So, when alcohol consumption is interrupted, the inhibitory GABA activity decreases while the excitatory glutamate activity becomes excessive. So, this excessive glutamate activity causes the autonomic hyperactive state seen in alcohol withdrawal, and the signs and symptoms include hallucinations, tremors, insomnia, agitation, diaphoresis, hypertension, tachycardia, and seizures. So it can affect the central nervous system and the liver. In the central nervous system, it can cause Wernicke's encephalopathy and Korsakoff psychosis. Wernicke's encephalopathy is an acute neurological condition caused by thiamine deficiency, and the patient may experience paralysis of the ocular muscles, ataxia, and altered mental status. In Korsakoff psychosis, it is a neurodegenerative disorder that results from prolonged thiamine deficiency, and it is basically a syndrome of confusion in which patients experience confabulation. In the liver, it can cause hepatitis and cirrhosis. Hepatitis is the inflammation of the liver caused by chronic alcohol consumption. This can cause jaundice, hepatomegaly, ascites, and elevated liver enzymes. And cirrhosis results from end stage alcohol liver disease, in which the liver cells are destroyed and are replaced by fibrous tissue. Patients potentially develop portal hypertension, ascites, esophageal varices, and hepatic encephalopathy. So the cues. On admission, his heart rate was 102 and his blood pressure was 147 over 100. His CWAS score was 30. He had severe tremors and he was hallucinating. He said he was seeing angels in the room. His ethanol level was 199.2, and for reference, it should be less than 3 milligrams per deciliter. And both his barbiturates and cannabinoid screen were positive. On my clinical day, his vital signs were stable. He had a temperature of 97.8 Fahrenheit, a blood pressure of 128 over 62, a heart rate of 76, a respiratory rate of 18, and his oxygen saturation was 95% on room air. His physical assessment. So he had tremors, he was irritable, anxious, and depressed, and he reported abdominal tenderness in the lower quadrant, and he also reported bladder irritation. He was malnourished, and he stated that he replaces meals with alcohol. And he said that when he would eat, he usually recurred to fast food meals. He was a two-person standby assist, and he had an unsteady gait. So now we are going to analyze the cues. So the elevated heart rate and blood pressure are the result of the autonomic hyperactive state seen in alcohol withdrawal. The CWIS score of 30 indicates that the patient is experiencing severe withdrawal. The severe tremors and hallucinations are consistent with alcohol withdrawal due to the disruption of the inhibitory and excitatory signals. The ethanol level of 199.2 measures the elevated alcohol levels in the bloodstream. Per Health and Physical, the patient drinks 6 to 8 beers per day, and the positive barbiturates and cannabinoid screen indicate that the patient may have consumed recreational drugs that further depress the central nervous system. So now we are going to analyze the cues for my clinical date. So the tremors were still there. His alcohol withdrawal had been stabilized and the CWIP protocols had been discontinued. However, the tremors still persist due to the autonomic hyperactive state during alcohol withdrawal. He was irritable, anxious, and depressed, and this is attributed to his situation. He was about to lose his dog if he agreed to go to post acute rehabilitation, which is something that he didn't want. He didn't want to lose his dog, so those feelings are attributed to that. Abdominal tenderness in the lower quadrant and bladder irritation are possibly attributed to the benign bilateral epididymal cyst per ultrasound impression, and malnourished. So the patient stated that he usually replaces meals with alcohol and reported that when eating, he would usually order fast food meals. Per patient, Meals on Wheels delivers food to his apartment, but he says he doesn't really like it, and two-person standby assist and unsteady gait. So this could possibly result from a sedentary lifestyle and also his poor nutritional habits. The analyses of the lab values. So the red blood cell, the hemoglobin, and hematocrit levels were low. These low hematology values are possibly attributed to the patient's poor nutritional habits, as he does not consume foods high in iron or folate. The liver enzymes were elevated, and these are possibly attributed to the mildly diffused fatty liver per CT impression, and the decreased albumin level may indicate impaired liver function, inadequate protein intake, or malnutrition. So my priority nursing diagnosis based on all of these cues was 1, impaired physical mobility, and 2, ineffective coping. So, impaired physical mobility is my first priority nursing diagnosis because it was a reason for the patient's prolonged hospital stay. Per physical therapist, the patient required two-person standby assistance to transfer out of bed due to his unsteady gait, and the patient needed to be placed in a post-acute rehabilitation center where he would get the overall recovery support that he needed. And ineffective coping was my second priority nursing diagnosis because the patient was initially admitted for alcohol withdrawal. The patient did state that drinking is his way of alleviating the pain caused by the loss of his friend, and the alcohol withdrawal had been controlled, and the CWIP protocols had been discontinued by my clinical date. So now we are going to talk about goals. For impaired physical mobility, my goals were the following. By the end of this 8-hour shift, the patient will verbalize at least 2 ways in which physical therapy benefits his recovery. The patient will verbalize the importance of selecting at least 2 meal options high in protein, and the patient will verbalize agreement to post-acute rehabilitation. For an effective coping, my goals were the following. By the end of this 8-hour shift, the patient will verbalize at least 2 harmful effects on his vital organs caused by chronic alcohol use. The patient will verbalize at least 1 healthy alternative coping strategy to use when feeling depressed. And the patient will verbalize at least 1 reason why substituting meals is a negative coping habit. So now I am going to talk about multidisciplinary interventions for impaired physical mobility. For nursing interventions, the first one was implement appropriate fall precautions. The rationale is that the patient is at increased risk for falls as he has an unsteady gait. This was effective. The bed alarms were activated, the side rails were up, the patient wore non-skid socks, and his call light was within reach. The second one was assess the patient's muscle strength during shift assessment. The rationale is to obtain baseline mobility, and it was effective because during my shift assessment, I found that my patient had bilateral lower extremity muscle weakness and he required a two-person standby assistance. The third one is assist patient with ambulation using a walker and a gait belt. The rationale is that these provide support and stability, and it was effective because my patient was safely transferred using a walker and a gait belt. The last one was educate patient about importance of selecting a high protein meal from the meal menu. The rationale is that adequate protein intake is essential to strengthen muscles. This is progressing. The patient was receptive towards education. He did select scrambled eggs, toast bread, orange juice, cranberry juice, and for his breakfast, he ate 50% of his tray, and for lunch, he did eat about 75%. For pharmacological interventions, folic acid 1 milligram by mouth as scheduled. The rationale is that it treats folate deficiency and supports physical mobility. It was effective because 1 milligram was administered. Thiamine 100 milligrams by mouth as scheduled. The rationale is it treats thiamine deficiency and supports mobility. And it was effective because 100 milligrams were administered. Other interventions include physical therapy. The rationale is that physical therapy evaluates mobility status and formulates a plan to improve patient's strength and balance. This was effective because the patient was seen by the physical therapist and helped them perform range of motion exercises. The second one was post-acute rehabilitation. The rationale is because it was recommended by the physical therapist as the patient lives alone and he needs assistance to complete his ADLs. And I am not able to determine the effectiveness at this time. And a registered dietitian, the rationale for this intervention is to provide education about nutritional intake and formulate a meal plan. This was not effective because the patient was not seen by a registered dietitian during my shift. Now I am going to talk about the multidisciplinary interventions for ineffective coping. For nursing interventions, the first one is to use verbal and nonverbal therapeutic communication approaches. The rationale is that open-ended questions allow patients to reflect on substance use behaviors. This was effective because the patient verbalized the negative outcomes of chronic alcohol use. The second nursing intervention is to encourage the patient to verbalize feelings, triggers, and stressors that contribute to alcohol use. The rationale is that identifying factors that contribute to alcohol promotes self-awareness. This was effective. The patient stated that the loss of his friend contributed to consuming more alcohol than usual. The third nursing intervention is to identify which family members the patient can count on to support him through his discharge plan. The rationale is that identifying available support system enhances recovery outcomes by providing emotional support. This was not effective because the patient said that he does not have any close family members or friends. The fourth nursing intervention is to educate patients about alternative healthy coping mechanisms. The rationale is that educating patients about counseling, meditating, or journaling promotes healthier stress management. This was effective. The patient said that music therapy has worked for him in the past. Pharmacological interventions included folic acid 1 milligram by mouth as ordered. The rationale is that it corrects folate deficiency caused by alcohol use disorder, and it was effective. The second one is thiamine 100 milligrams by mouth as scheduled. The rationale is that supplementation is essential to prevent Wernicke's encephalopathy, and it was effective. The third one is chlordiazepoxide. The rationale is that a benzodiazepine prevents acute neurological complications like seizures. It was effective, however, the order had been discontinued. Other interventions include case management. The rationale is that a case manager coordinates discharge planning according to the patient's needs. It was effective. The case manager continued care coordination and arranged home health services to support the patient's needs after discharge. Alcoholics Anonymous. The rationale is that a support group is appropriate for his recovery. This is an opportunity for the patient to learn from others experiencing alcohol use disorder, it was not effective. The patient was not given an Alcoholics Anonymous referral during my shift. So, the evaluation of goals for impaired physical mobility, the first goal was met. The patient verbalized two benefits of physical therapy, including improved mobility and increased strength. The second goal was also met. The patient verbalized that adequate protein intake is needed to maintain muscle strength and to support mobility during physical therapy. The third goal was not met. The patient declined post-acute rehabilitation despite education provided, as he wishes to remain with his dog at home. Another intervention that I did to support this goal was to notify case management to arrange a different discharge plan. So the patient determined that home health management would be a better fit for him. Evaluation of goals for ineffective coping. The first goal was met. The patient verbalized that due to his alcohol use disorder, he could develop liver cirrhosis and experience another severe withdrawal. The second goal was also met. The patient verbalized that music therapy has worked for him in the past and that he is willing to use this coping strategy again. The third goal was also met. The patient verbalized that using alcohol instead of eating is a negative coping habit because it reinforces his dependency on alcohol.